All right. I want to thank everybody for inviting me to talk to you today. We're going to talk a little bit about a few of these issues, and if HSI takes 5 seconds to process and we're not quite getting there with 7 seconds of disclosure, I'm not sure what kind of future it has, but I'm excited to see that the software evolve. So my objectives are to, there's really not a lot of new exciting things for sigmoid volvulus. The operations are typically the same, but I do think that it's almost invariable that you have, young residents that are rounding, and a lot of times they ask about, just PEC-ing things to try to get away with minimal operations. So we'll try to review some of the outcomes on that literature. I typically like to also point out that a lot of large bowel obstructions, not a lot, but a fair bit, sometimes can just be physiologic. Ogilvy's and even constipation can be so severe that it can oftentimes be mistaken for an obstruction, and I typically try to keep the classification system very straightforward and systematic. We've spent most of the day talking about cancers, which would be intraluminal, or diverticulitis is more intramural with the stricturing. And so this is going to be extraluminal causes and things that can also contribute to a bowel obstruction. I think most of us too have seen this a few times at least. Volvulus is not incredibly common in the United States, but I'll show you a map here pretty soon. In other parts of the world, it's pretty common, up to about 13 to 40% in the volvulus belt. Overall, the cecal volvulus are much more rare than sigmoid volvulus, and the bascule is a subtype of a volvulus, which we'll get into. And then we'll also briefly talk about intussusception, especially in the colon. I know that, we typically will see it on imaging in the small bowel, and then they call a surgery consult and they say, oh, it's fine, it's going to go away. You may have caught peristalsis in an interesting time period. Colonic intussusceptions are almost always surgical, but thankfully they happen pretty rarely. So this is our volvulus belt. Typically around the equatorial countries, this is where the incidence of volvulus can be up to 40 or 50%. We don't really know the exact cause for this. I think that it's either, some studies have thought maybe it's altitude, maybe it's infectious, maybe it's dietary. So the actual cause or etiology of the volvulus in these areas has yet to be elucidated. But like I said, luckily the North American instances are pretty rare. We know these risk factors are pretty well established. It's usually typically constipated folks, people that live in nursing homes, have neuropsychiatric conditions, are on multiple medications, or elderly or hospitalized. And those are the people that we would expect to see it in. I kind of I'm more of a visual person, so if you always think of the medial wall of that part of the colon goes down and out, so the cecum will typically volvulize in a clockwise position, and the sigmoid will go in a counterclockwise position, and it's more of an axial torsion on the mesentery. Specifically for the sigmoid volvuluses, it's more common in males, as we discussed. I do think that diabetes is a predisposing factor more from a dysmotility aspect, and these patients will tend to become more constipated. It's obviously a much more sudden onset versus the cecal volvulus can be more indolent and subacute. The other predisposing factors that I think it can be interesting is also people with a history of trauma. We've seen quite a few of them come back, not necessarily a year or two after their trauma, but ever since they had multiple lumbar fractures, they end up getting slow transit constipation that can predispose them to other issues. So this is the image that everybody knows and loves that I have never seen on any of my patients. And I actually had to, thankfully, Dr. Feingold lent me his picture to use. The coffee bean always points to the side that it goes to. If I had that image, I would probably still get a CT scan because I've never complained about having too much information. But in general, I think you're lucky if it ever actually looks like this. So the best test from a specificity standpoint, plain films, when you get that plain film, I think is probably at the 81%. Water-soluble enemas can reach that of a CT scan if you don't have a CT scanner present. But like I said, I'm a little bit biased as far as trying to figure out, is there free air? Is this really, I have never been in the operating room sad that I had a CT scan to fall back on. Typically on the left side, you can see that like definite bird's beak there where the colon is decompressed, and then you can start to see the mesenteric twisting on the around the mesentery, which is really what you're looking for to help secure that diagnosis. Unfortunately, a lot of these patients may be anticoagulated, so you kind of have to, while you resuscitate them and make sure that they're not peritonitic, then you can sort of go down a good pathway of treating this. Endoscopic detorsion on the sigmoid side is still, hopefully the first step that you can do. I typically do it in the operating room with a flexible sigmoidoscopy. That way, if I have any perforations, if there's ischemia, or if it just doesn't work, then I can just, roll them flat in the operating room table and do my thing. GI will also do these for us if it's not 1 o'clock in the morning. And the rigid proctoscope is a good trick to use. I have not done this because it's kind of tricky. You have to kind of waddle your proctoscope in and out around that and then get blasted in the face. But it's usually easy to put a chest tube through the proctoscope, and I think that works a little bit better because this is what can happen if you put a rectal tube through your colonoscope. They have these very small bore decompressive tubes that I like showing pictures of things that don't always work so that you kind of know this will guide me away from doing this in the future. This patient was transferred to me, and the rectal tube was just too flimsy, and the volvulus kind of like laughed at it. I think they got through it, and they put the rectal tube in, pulled their scope out, and then this is what was left. So the surgical options are really, you do need to resect this. The recurrence rate is very high, even if your endoscopic detorsion is successful. I think a lot of people, we all try to do things minimally invasive, but this is historically one of the easiest open operations you can do through an incision that's about the size of what you will need to take your specimen out anyway, because the sigmoid colon is so mobile and stretched out. I would, if you're able to detorse them and bowel prep them, I think that the permanent colostomy rates, especially if those patients are so high, a side to end is a great way to get away from your colon mismatch. And if you can put them back together, I think that has worked well for us in the past. I did look up some non-conventional techniques that I have not done, but I could see them being appropriate in certain instances. This one study in DCR had talked about a 2-point fixation of the sigmoid colon. They did it in 6 patients and had no recurrences at 10 months. On the one hand, you're taking, if the patient's so sick that they can't tolerate general anesthesia, that would be prohibitive to this. But I have had several patients that are just too decrepit, had horrible arthritis, can't take care of a stoma. So I think, it's something that's out there that's been described successfully. And then the study on the right, after they verified with their endoscopic detorsion that they actually detorsed it, then they did percutaneous fixation. Did not have long-term follow-up from that study. I probably would not do this either, but I have an open mind if I've learned nothing else through my training. So the 3 types of cecal volvulus are listed there. They usually, like I said, will go in a clockwise direction. And a bascule is not a volvulus on the mesentery. It kind of just flips forward from inferior to superior and will kind of serve as a closed loop to obstruction. So we all know the law of Laplace with the cecal volvulus. The endoscopic detorsion is just a little bit too risky with your cecum already being dilated. The chance of perforation is quite high. And your biggest options there are really just to do an ileocecectomy with an anastomosis. If they're unstable or if it's ischemic, you might want to consider a second look, because an ileostomy also in these patient populations that we're talking about can also be kind of life-limiting with ongoing readmissions for dehydration. Cecopexy has a very high recurrence rate. The best reports out there are 13% recurrence rate. And if you look at a study over the last 30 years of, well, more than 30 years ago now, but 561 patients, these options were not combined. They were all taken as the solo operation that they had done. Cectomy really had the highest mortality rate, by far the highest abdominal and wound rates from that tube eroding through the cecum or the abdominal wall. Cecopexy and resection and detorsion alone had similar recurrence rates and complications. I have had a couple patients sent to me with a cecal bascule, and luckily they had come to me more of an outpatient sort of setting where I had a CT scan proving that that certainly was suggestive of a bascule, and it resolved, and they just wanted to go home and follow up later. And you can have this thing called mobile cecum syndrome, where you get constipation, maybe some intermittent right lower abdominal pain, and then they get relief after things kind of work themselves out. The peak age for this is younger females, and it's usually either congenital from their ileal mesentery not being affixed to their pelvic brim, or having some sort of adhesions fixing the cecum to the anterior abdominal wall. And it's really not that clearly defined, but you do need to know that by definition, you sort of need to have a competent ileocecal valve to create that closed loop obstruction. It can be very difficult to tell really clearly until it's the time for your operation. And again, that's where a CT scan can typically help. And then lastly, I just want to talk about intussusception, especially with the colonic intussusception. The chances of a malignancy are very quite high, and I would typically not leave them in there. The zebras, I think that I was seeing, this is a patient that was from Latin America, and he had a very large diverticulum that had actually folded in, causing an intussusception when I scoped him, because he was 35, and I did not think that he would have a cancer, and I was trying to see what exactly was going on there. I was able to reduce this intussusception, and then you could see this pretty large diverticulum that continued to cause him some pain, so we went to resection and did an elective procedure. This was a tubulovillous adenoma that was benign, but it was also about 3 or 4 centimeters, causing a transverse colon obstruction. And then this is typically the sign that we all like to see. This was a sigmoid cancer that was also straightforward. Of note, you should also think about how long this patient has been sick or having pain, because when you have some ischemia, or if that area is getting agitated, it's actually ill-advised to do a endoscopic procedure or a contrast enema. The thought that you could possibly cause a perforation that may either upstage your tumor or really make the situation worse. So if it was an early type of intussusception, I think that's when I would head towards trying to decompress this. All right, I'll take any questions at the panel session.